Okay, fine. So let's test this. Come, let's test this. Let's be sure of sounds. What do
Excuse me.
I want to sign in another.
Okay, so sign here. Maybe you must speak before the presentation starts. Supposed to give you a lesson about Is it going to stay like this? We won't be able to. Oh, why don't you record from an angle?
This is
Okay, check out this. Because you want to be able to be stretching. Just confess that this may become control because it's something what's not. This is where I'm moving. Unless, where is the mouse? I think the mouse is serious.
I also have some people.
you want to wait?
Yes.
No, I'm trying to say because this is how the system is being like that. It's very stretched for us to.
This is connected to the system too.
Break your glasses.
let's I'll discuss this. It's already
So how far with audio? Because it matters.
Okay, another thing again, if it's positioned like this, will this camera become clear?
I want to be sure. First, did you can't face ourselves?
So you might get interested.
So this is the camera we're looking at.
Is this the camera? I don't forget this one.
We need some cameras catch areas.
Dr. Akiri, my phone is inside.
Expensive phone.
Thank you so much. I didn't
Not yet.
Yeah. Okay, hello, good day, everyone. Okay, no, I've not. Okay, hello, good day, everyone. Yeah.
Hello, you're all welcome to today's presentation and webinar. We welcome our virtual and physical audience here with us. This is the presentation sponsored by the Limi hospitals.
All right, so
We'll be starting in a few minutes' time.
okay, good day, dear listeners. We are running a hybrid webinar today with both our physical audience seated and our virtual audience connected. Happy to have you join us today at our Limi Hospitals webinar. This is sponsored by the Limi Hospitals, which currently we have 3 hospitals. The Limi Hospital, the headquarters in Central Business District in Abuja, the Cardio Care Cardiovascular Multi-Specialty Hospital in Gariki, Abuja, and then the Limi Children's Hospital. The broadcast for today is coming from the Limi Hospitals, the Limi Children's Hospital. So the Limi hospitals, I've talked about the branches. Our service and activities are centered around the following. We, as displayed on our screen, we have our Neonatal Intensive Care Unit displayed. Other services we run include pediatric cardiology and neonatal cardiology services, pediatric nephrology, developmental pediatric services. We have services of transport incubator and pediatric endocrinology clinics. We have displayed here our pediatric cardiologist performing echocardiography in a preterm who is inside a transport incubator. We will go straight to the presentation today.
Our topic for today is low birth weight neonates in resource-constrained settings. We are focusing on the strategies for clinical management. My name is Dr. Ijere, and with me is...
I'm Dr. Igor Chepita. Happy listening. Yeah. So a good start in life begins in the womb. So we all started somewhere, and it's important how the baby fares inside the womb. We have this display on the screen showing the nurse listening to what the baby is saying, listening to the baby's nursery rhyme. That is a heart, fetal heart. Yeah.
Okay, so our case scenario, what we're focusing on, case scenario for today is a 6-hour-old preterm female weighing 1,300 grams, a 30-weeker who was delivered vaginally by a 37-year-old multi-gravida who was on treatment for urinary tract infection, was referred from another specialist hospital due to lack of birth space. The baby was transported by the mother with the public transport. No healthcare worker was accompanying them. The child came hypoglycemic with a random blood sugar on arrival of 2.2 millimole per liter. The child was also tachypnic, respiratory rate 78 cycles per minute, and saturating at 90%.
Okay, so along the course of this presentation, we would like to have our audience answer within the chat box. I would like us to be able to classify what is the birth weight classification of this baby that was just discussed. Can you please list the risk factors for prematurity in this baby? Also, would like to have you list the immediate health challenges this baby would face, and then how will you manage those challenges that you have listed. I also want to know, how should this baby, what was the best way of transporting this baby to us? So along the course of this discussion, we would touch all this, but I would like to know the preliminary information you may have regarding this. So what are our learning objectives today for our audience?
Okay, we hope our audience, both virtual and physical, would, by the end of today, know who a low birth weight neonate is, the possible causes or risk factors that will lead to a neonate having a less than expected weight. What are the short-term and long-term challenges? That's the challenges we expect to see within 2 to 3 days of life, and then the long-term challenges of this low birth weight neonates. We also would hope that you will learn how to handle these challenges when faced with a low birth weight neonate.
All right, thank you.
So this is going to be answering now, who is a low birth weight neonate?
So a low birth weight neonate, according to World Health Organization, is a baby delivered with weight at birth below 2,500 grams. Now, we have to use the weight in grams because I think it's less dignifying to use kilograms. So we have babies who weigh 900 grams. Now, will you say 0.9 kg? That will be less dignified. So we use grams. So a baby that weighs less than 2,500 grams. So from 2,499 grams and below, regardless of the gestational age of the baby is low birth weight. It is further classified to very low birth weight and extreme low birth weight babies. So if the baby weighs less than 1,500 grams, the baby is very low birth. So also weighing less than 1,000 grams is extreme low birth weight. Yeah, the concern, yeah.
Yes, some people may be confused about this. So where do 1,500 grams fall under? Then where do 1,000 grams fall under?
So a baby who is 1,500 grams is still low birth weight. The baby has to be below 1,500 grams to be classified as very low birth weight, provided the baby is not below 1,000 grams.
So a low birth weight neonate comprises of both those that came in those that were delivered preterm and those with intrauterine growth restriction. This both fall under low birth weight neonates, irrespective of the gestational age of the neonate.
Okay, so she talked about prematurity as one of the class of those who have low birth weight. And the preterm unit is one delivered before 37 completed weeks of gestation. Now, just like we classified birth weight as low birth weight, very low birth weight, and extremely low birth weight, we also have the classification of prematurity as extremely premature baby, extreme preterm, early preterm, and the late preterm. So the extreme preterm babies delivered below 28 weeks of gestation. Now, below 28 weeks is benchmark of fetal viability in our environment. However, because we're talking of resource-constrained settings, developing countries. However, in our care in the Limi hospitals, we've been able to manage comfortably babies up to 26 weeks. So really extreme preterm babies successfully. So a baby that is below 34 weeks is early preterm. And then if it's between 34 weeks and 36 weeks, that's late preterm. As a matter of fact, with good clinical care, no baby who is early preterm or late preterm should die from complications of prematurity.
So a neonate that is small for age could be either classified as constitutional small for gestational age or intrauterine growth restriction. Now, those that fall below the 10th percentile for age, as can be seen in the graph on the screen, which will be further explained, can be classified as either symmetrical or asymmetrical. Now, symmetrical has to do with the child having all body parts being small for age, including the OFC and other body parts, while the asymmetrical means the OFC could be adequate for age, but the length of the baby, the weight of the baby will be small for age. So irrespective of the gestational age, this small for gestational age babies could be either preterm, full term, or post-term, which is greater than 48 weeks gestational age.
Yes, so let's look at the placenta charts in front of us that was referred to. So we have one of the curves labeled 10th centile, and we have another curve labeled 90th centile. Now, babies that weigh between 90th centile and 10th centile are appropriate for gestational age, whereas baby that weigh above the 90th centile at any gestational age are large for gestational age. Today, we are talking about babies who weigh below the 10th centile. These babies are small for gestational age. So intrauterine growth restricted babies are small for gestational age. Now, if we look at this graph closely, we look at the horizontal axis telling us about the weeks, gestational age in weeks. And we said that below 37 weeks, where my pointer points now, every baby below 37 weeks is preterm. So a baby who is, say, 36 weeks and then weigh 1,500 grams. Let's plot and see. 36 weeks, 1,500. This is at this point. The baby is going to weigh below the 10th centile for age, and therefore the baby is low for gestational age, so low birth weight. Now, is preterm low birth weight because the weight is still at the point exactly 1,500 grams. Below that, you now start saying very low birth weight, extreme low birth weight. Now, if we shift to babies above 37 weeks of gestation, now become term babies. So these babies are now term up till 42 weeks. So for example, if we get a 40-weeker, if you're looking at the screen now, we get a 40-weeker that weigh 2,500, a 40-weeker weighing 2,500, by this percentile chart is low birth weight because it's weighing below the 10th centile for gestational age. So whereas 2.5, that's 2,500, would be appropriate for gestational age for a, say, 37-weeker, it won't be for the gestational. So even if you switch further for post-term babies, say delivered at 43 weeks, the same thing applies. So irrespective of the gestational age, provided the weight falls below the 10th centile, is small for gestational age, low birth weight babies. Yes. Okay, fine. So we'd like to know how common, what is the burden of this disease, low birth weight babies?
So low birth weight neonates is a problem globally, is of public health relevance because we have like 15 to 20% of all babies delivered worldwide fall within this range of low birth weight.
Yeah, so when you say 20%, that's you're saying like out of every 5 babies, 1 is delivered with low birth weight. As serious as that. 1 out of every 5 baby. Yeah, okay.
And this accounts for over 20 million births a year. So one of our goals, the World Health Assembly goal, which is also falls under the Sustainable Development Goals, is to achieve a reduction in low birth weight by 30% in 3 years' time. That's 2025. Yeah. So we hope that with this presentation, all of us can actually know what we can do and what role we can play in helping to achieve this goal. Low birth weight is a major predictor for prenatal mortality and morbidity, and also increases the risk of non-communicable diseases like cardiovascular disease or diabetes mellitus later in the child's life.
Okay, thank you. So we have, so please, we appreciate questions placed in the chat box. So we'll be answering questions as we progress. Are low birth weight and small for gestational age synonymous terms? No, they are not. So low birth weight, so let's go back to one of our slides that simply explains it. So low birth weight babies, that is an umbrella term for babies who are born preterm, who have intrauterine growth restriction. So the weight for the gestational age of the baby is not appropriate. And we said, if we look at the percentile chart, babies that fall below 10th centile are low birth weight babies. So whereas small for gestational age can be constitutional small for gestational age, or because there was intrauterine restriction of growth. And that intrauterine restriction of growth could be something that occurred early in gestational age, then it is symmetrical. So occipitofrontal circumference, length of the baby, the weight of the baby, we all symmetrically fall below the 10th centile for age of that baby. Whereas if it's occurring much later, because there is head sparing, the baby had acquired normal occipitofrontal circumference at that point, but there is terminal fetal malnutrition, the baby will have asymmetrical. So just like we have, I think the explanation is a little easier with using macrosomic babies. We have macrosomic babies that are infants of diabetic mothers, but not all macrosomic babies are infants of diabetic mothers. They are large for gestational age. Large for gestational age will be said to be macrosomic. But large for gestational age could be constitutional or could be due to those that are from infants of diabetic mothers. So the question we state, are low birth weight and small for gestational age, are they synonymous then? Small for gestational age is a class that we have as constitutional small for gestational age and then intrauterine growth restriction. these form one arm of those that are low birth weight, whereas the other arm are those that are preterm. Now, babies who are small for gestational age because of intrauterine growth restriction, this can occur even in preterm babies. So we now have a preterm that on the basis of prematurity alone would have been low birth weight, and that baby also further suffered intrauterine growth restriction, symmetrical or asymmetrical. Yeah. Okay, I hope that answers that question. Thank you.
Okay,
so we'll make some
we'll
more
go ahead with our presentation. So looking at the United Nations data, we can see for us here in Sub-Saharan Africa, of course, Nigeria falls under West Africa. Percentage is at 14% infants are born with low birth weights. If you look at the entire chart, it will seem like we are winning, but really, a lot of these babies are not even captured. So because we have like the second highest percentage of infants that are not weighed at birth, that's 60%. So more than half the babies delivered are not even identified as low birth weight because they are not even weighed. I think the only people that are ahead of us in this is South Asia, that is at 66.
66.
So that already poses a problem. We can't even classify them. We can't identify them first and foremost to even provide the care that they need. Yeah.
Okay, fine. So that's really serious. If we have problem with data collection, we cannot even tell the magnitude of our problem. So as simple as having appropriate weighing scale for babies matter a lot, and it's a problem in Sub-Saharan Africa. Well, we'll proceed. Good. So, but let's look at the picture of what obtains in Nigeria. What obtains in Nigeria? Now, newborn health is one of Nigeria's worst health challenges. So we hear a lot about HIV, a lot about COVID recently, a lot about malaria, a lot about pneumonia. But let's say, let's put this fact straight that newborn health is one of Nigeria's worst health challenges. We have the highest burden of neonatal deaths in Africa. So this is not a good point to talk about being giants of Africa in terms of neonatal deaths. We do not want that. And that's why the Limi hospitals is contributing to public awareness as part of a give back to the community. After 40 years of great healthcare, we would want to go beyond to disseminate information. So if we have this kind of statistics, it makes us all to worry. We have the highest number of neonatal deaths, about 700 deaths per day, about 700 neonatal deaths per day. And that to say, every 1 hour. So if we're going to, from when we started this webinar, by the time we reach 1 hour, 29 babies would have died. That is the picture of what obtains in Nigeria. And out of these that die, of course, there's a significant contribution from the low birth weight neonates because of the challenges they have that we shall see. What is the ray of hope we may have is that 80% of these deaths are preventable with cost-effective interventions, which we shall discuss as we progress in the discussion. So we want to look at some risk factors. What are maternal risk factors?
Okay, so the maternal risk factors, of course, age is one of them. Extreme of ages, women that are above 35 years and those below 16 years are at risk of having low birth weight babies. Of course, those of younger age groups would have intrauterine growth restriction in their children, most likely because of poor nutrition, them not being able to take care of themselves because they still fall under the children wing. So they will not be able to even feed the baby well.
Yeah, so they are children in terms of age, but getting pregnant below 16 years, they graduate to a class we call emancipated minors. So the definition of childhood children, we still say we peg it at 18 years. But before that, there are a few things that now emancipate them from that classification. I don't think that emancipation is actually very healthy, both to the mother and to the baby. Okay.
Frankly, the emancipation is not for everything. It just covers some of their social aspects.
Yeah.
Then there are other personal factors which affects us in Sub-Saharan Africa. poverty, malnutrition, substance abuse, which is also on the rise among young people, most especially. Medical conditions and infections. We saw a case scenario, the mother had urinary tract infection.
Oh, so let's
factor.
check the chat if we've had any of those answers. And let's know whether we are talking to ourselves. Oops, nobody has answered any of our questions. Permit me to go back maybe and read the questions. We have more participants online now, so we know exactly what we are trying to answer in the course of our presentation. So we have this 6-hour-old female neonate that was delivered preterm with 1,300 grams weight at 30 weeks of gestation. Mother delivered vaginally, and she's 37 years old and a multi-gravid mother. Was being treated for urinary tract infection as at the time she delivered. Referral was from another hospital, another specialist hospital actually. They referred because they didn't have bed space. The baby arrived via public transport, carried by the mother, no healthcare worker accompanying them, random blood sugar. We will not interpret our results. We want you to work out what the figures mean. Random blood sugar on arrival was 2.2 millimoles per liter, respiratory rate 78 breaths per minute, while oxygen saturation was 90. We've been able to classify this baby as what? Very low birth weight baby. Now, we were at listing the risk factors for prematurity. Let's see. Okay, we're trying to list the risk factors for prematurity in this baby. I want to know what are the health challenges immediate. How will you manage them? And we want to know exactly how should this baby have been transported on the mother's lap using Uber, the mother that just delivered. This happened real life. This is not one of those concocted stories. We actually treated the baby in our facility here. Okay, so let's go to risk factors. Okay, fine.
So we're discussing the maternal risk factors.
Okay, so we have an answer. We have an answer. Wow. Okay, fine. So birth weight is low birth weight. Yes, the baby is low birth weight, but wanted to move from mathematics to further math. So is low birth weight, but this is actually very low birth weight. Very good answer. Risk factors, yes. The person said UTI, yes.
That's true.
That's true. Multi-gravid, yes. Possible malnutrition. Well, fine.
Not
fine.
really indicated.
Okay, fine. So the health challenges, sepsis, congenital defects. So we admit nutritional support.
Okay.
Yeah, antibiotics. So transfer using ambulance with neonatal cot ideally. This last answer, we will talk more about it. We will talk more about it. So Joe and Uka answered correctly, very low birth weight. Okay, fine. So this mother had, risk factors, medical conditions, infection. So the mother had urinary tract infection. So it's a risk factor for preterm delivery. And the mother was 37 years. Mothers above 35 years risk having babies who are low birth weight babies. So what are obstetric factors?
Okay, so a woman who has had a preterm delivery is also at risk of having another one. If you have a premature rupture of membrane, there's also a risk. Of course, that leads to risk of infection, still falls under the medical conditions. Then the touch infections, that's toxoplasmosis others. You know what others are? Varicella zoster is one of the others. Then syphilis too. Then rubella virus. Then cytomegalovirus, and then herpes virus. So okay, the fetal parts.
So for the fetal, so risk factors could be maternal and fetal. So for fetal risk factors, babies who have congenital anomalies, these babies are not functioning optimally. They cannot stay as long as possible. So they come out quite early. That is for those who are preterm. And congenital anomalies, this is a problem with the genetic abnormalities. It's a problem that sometimes could be associated with the symmetric type of intrauterine growth restriction, because it's a pathology that they carry right from first trimester. Now, interesting for our audience to pick from today, for those who may not have known, that everybody in the community can help in making a diagnosis for genetic abnormalities. So with our Android phones, if you go to Play Store, you can search for Phase 2 Gene app. So with a Phase 2 Gene app, the mother can snap the face of the baby, send to the doctor, and the app would process the accurate diagnosis of the genetic abnormality of that child. So it's important we know that that's like making life a lot easier for current day clinical practice. Babies who have congenital anomalies, genetic anomalies, would have intrauterine growth restriction. Babies that are delivered from multiple gestation, it's a risk factor for preterm delivery because the space constraint. So the tenants are too many inside the accommodation. So preterm delivery is quite common. And most times the obstetricians will prefer to deliver them before fetal distress sets in. They're also prone to intrauterine growth restriction. Okay, babies that are delivered from assisted reproductive technologies also are likely to have to be low birth weight, either because of prematurity or also the intrauterine growth restriction. So we've seen one of our audience asking, okay, by name Moses Effiong, can you please repeat the name of the app? So it's Phase 2 Gene, Phase, then 2 as a digit, not TWO, Phase 2 Gene. If you check your Play Store on Android, you get it. So let's look at assisted reproductive technology conceived babies. So there is this systematic review done in Taiwan. Over a 6-year period, 50,000 live births delivered, conceived by assisted reproductive technology. You know, we're talking of IVF, intracytoplasmic sperm injection, and the various technologies that will. So they checked how prone they were to delivery as low birth weight babies, as preterm babies, and the prevalence of birth defects in them. This was obviously a very large study. They found that children conceived by assisted reproductive technology displayed a higher rate of low birth weights when compared with those conceived naturally. This difference was statistically significant. So when they went further through regression analysis to compare with what if it were singleton, because we know that multiple gestation is common with IVF. So what of those who were conceived IVF or singleton? Compare singleton IVF, singleton normal conception, they still weighed significantly less. So in terms of low birth weight, that is being small for gestational age, talking of intrauterine growth restriction, and those who were delivered too soon, that's preterm delivery, it was still far common among those conceived by assisted reproductive technology. So we bear this in mind. The fact is that it does not negate, it doesn't mean people shouldn't go ahead, but this being done will require more close antenatal monitoring and ensure that delivery is in a safe place. Fine. So how do we identify babies that are delivered low birth weight?
Essentially, it's the simplest of tools, a weighing scale.
Yes.
Once a baby is delivered, the baby should be weighed.
Yeah.
And so once you have that, everybody now can get a weighing scale. It's easy to buy, it's everywhere. So that is one of the cost-effective tools that we talked about initially. So with this, you'll be able to at least identify if the baby is a low birth weight baby or not.
So this weighing thing becomes very important, because we found from the United Nations chart that showed the epidemiology that up to 60% of babies born in sub-Saharan Africa are not weighed. So you don't even know. So it's that bad. So it's important to be able to weigh these babies. There are special scales for them, for their weight. That some with a scale, a measuring tape that you can both weigh them and take their length at the same time. Yeah.
So we could also use the new ballot scoring for neonates. That's to help supplement the obstetric dating. Because of course, some pregnant women will give a date, but they are not very certain of their last menstrual period. And even then, they would have to depend on ultrasound scans, which if done in late pregnancy is not very accurate. So this ballot scoring system, on our part, the pediatricians, when they have the babies, they still try to classify the baby using the ballot scoring system.
Okay.
So though this system is effective, it still has its drawbacks and limitations. We'll discuss that further.
Yeah. Okay, so there are basically two parameters that are broadly two parameters that are considered in the new ballot scoring system. We'll first of all look at the neuromuscular maturity rating and then the physical maturity rating. So there are 6 parameters each. So let's know about them.
Okay, so there are 6 parameters. There's the posture of the baby. That has to do with the baby being in a supine position. You check how the baby's tone is in terms of the position of the upper limbs and the lower limbs. If you can see the chart, you see the scoring.
Okay, so sorry we had a break in transmission. Sincere apologies for that. We will continue immediately.
Okay, so we're at looking at the balance scoring system, the first parameter, which is the neuromuscular maturity. So we look at the posture of the baby. In a supine posture, you assess the tone of the baby.
Okay, so essentially the tone matures. As the baby gets older, the tone gets more prominent, the tone improves. So you have floppy babies with lower scores and then babies with good flexion scoring the highest in this one.
Okay, we look at the square window, which assesses the wrists. It's basically the same thing, except that you're looking at the wrist and the angle between the wrists.
Yeah. So for arm recoil, so we would like to handle 2 parameters simultaneously because of time here. So for arm recoil and for popliteal angle, we are trying to see the baby in supine position, you extend and see how it goes back into flexion around the elbow and around the popliteal angle. So cubital fossa popliteal angle. So the ones that are more mature, there's more flexion there and they are scored higher. The scarf sign is also one of the features. So the baby lies supine, just like when you want to assess for posture. And then you want to move one of the hands, let's say the left hand now, see how far it can go towards your right elbow. And you check the location of the elbow joint relative to the midline of the chart. These charts help to make it a lot easy for us to follow as we do that. So heel to ear is like exaggeration of the popliteal angle when you are checking the popliteal angle. Like we said, there is a major drawback to neuromuscular maturity rating. A baby that is older but delivered asphyxiated would be floppy and so give you lower scores. A baby who has myasthenia gravis, a baby whose mother or probably was under sedation and it's having effect of drug withdrawal, so that they will have all that. So
Even Down syndrome
even
babies.
Down syndrome babies. Fine. So we look at the physical maturity. We won't speak so much here because it's
Quite
self-explanatory.
yes.
But then we say there are 6 because we look at the skin, presence of lanugo hairs, plantar surface, the breast, ear, and eye. Then the genitalia for males, genitalia for females. Those are the 6 parameters in all. But there is a little challenge here. What if the baby has ambiguous genitalia, disorders of sexual differentiation? That is another major challenge with using this. But then that's the best tool, and those will even help for proper examination of the babies on time. So,
okay, so when this is done, you can use, based on this scoring chart, assess where exactly the baby falls under how many weeks gestational age you can classify the child as.
yeah. So the sum of the physical maturity and the neuromuscular maturity is summed up. So it falls under score in our table here under score. So if it gives 30, then the baby is 36 weeks of gestation. If it gives 25, then the baby is 34 weeks of gestation. So just as simple as that. Fine. So now we've had some answers to our question because we want to discuss the challenges of babies born with low birth weight. But let's look at the answers that some of our audience have raised. Okay, fine. Challenges. Okay, risk of sepsis, hypoglycemia, low oxygen saturation. Very good. These are good answers. We will see there is another. Okay, fine. So go ahead. Now, challenges are system-based, and you talk about the systems. Yeah.
Okay, so for the respiratory system, we have the acute and chronic challenges. For the acute problems that we've noticed, the respiratory distress syndrome, which we can see tachypnea could be one of them. The child could be desaturating too. We also have apnea.
Okay, so concerning respiratory distress syndrome, this is common. It's commoner in premature, that's preterm babies, in the subclass of those who have low birth weight. But I dare say that respiratory distress can occur at any weight of the baby and whatever gestational age, depending on some factors. The absence or deficiency of surfactant is the main problem in this case. So babies who are born very preterm babies have the deficiency of secretion by the type 2 pneumocytes and surfactant that help to maintain surface tension. So you see, the baby inhales, exhales, so you don't want the alveoli to collapse. It helps in aeration. So for the lubrication of normal compliance, lung compliance, the surfactant is necessary. So if it is deficient, the function is absent, and so the baby is present in respiratory distress. Respiratory distress here manifested by tachypnea, and so abnormalities of respiratory rate, use of accessory muscles, presence or absence of cyanosis. So these babies would have a ground glass appearance on chest radiograph, and that's why they're also called, it's also called hyaline membrane disease. These babies will require administration of surfactant as fast as possible. Also, before I am asked, because I categorically said that I can beat my chest that respiratory distress can occur at any birth weight and at any gestational age. So take a macrosomic infant of a diabetic mother who was delivered at term. The hyperglycemic environment the baby was exposed to triggers hyperinsulinemia, and this antagonizes the constituents of surfactant. So surfactant is produced, but deficient production. So there's a problem with the quality of surfactant. Unlike the respiratory distress syndrome in preterm babies, there is absence, that is quantity is not there. But for these babies, the constitution, it may be there, but it's deficient. So that's a problem. So that's respiratory distress syndrome. What one has to do, we will look at the management later in all. So you're talking about apnea.
Yes, apnea is also one of the challenges. Of course, apnea is cessation of breath for over 20 minutes in 20 seconds, sorry, with the presence of bradypnea, that's reduction in the respiratory rate and also desaturating with cyanosis. Then the chronic challenge is bronchopulmonary dysplasia. Do you want to?
So bronchopulmonary dysplasia is chronic lung disease. Also, chronic lung disease, bronchopulmonary dysplasia. These children who would have been exposed to long-term oxygen therapy. And then the current trend, which we shall see in management, we want to avoid 100% oxygen as much as possible, because we may think it's doing good to help the baby, but babies should have blended oxygen delivered. So it's a problem caused by, so oxygen is a drug, and then we must be clear of the indication of the drug oxygen we are giving. That's one. And must be clear of the dose of oxygen. So when we talk about dosage of oxygen, we're not talking about 2 liters per minute, 3 liters. We're talking of the fraction of, that's FiO2, fraction of inspired oxygen that is being delivered. And this must be very clear whenever oxygen is being prescribed. Yeah.
So going to the neurological challenges, we have the acute and chronic as well. Of course, this low birth weight neonates are at risk of intracranial hemorrhage and perinatal depression. They're also at risk of periventricular leukomalacia in the long term. Then cardiovascular, they're at risk of the patent ductus arteriosus. This is not the same as the PDA seen in the term baby. This is more of the fact that they are premature, so they come out before time. So we still see that the hole is still patent. And the treatment in this case, of course, with time, for the PDA seen in 10 babies, with time, it could close up on its own. But for this case, might require drug therapy such as NSAIDs and paracetamol to assist in the closure.
Yeah, so patent ductus arteriosus. I'm sure if we remember embryology, we know that everybody intrauteri, there is a ductus arteriosus, which connects just below the arc of the aorta at the bifurcation of the pulmonary trunk. The ductus connects between that bifurcation to the inferior part of the arc of the aorta. Now, why do we have ductus arteriosus? It's necessary because in utero, the lungs are collapsed and oxygenation is performed by the placenta. So there is no oxygen exchange going on in the lungs, and the pressure on the sincere apologies, we are back on air again. So I was talking about the intimal proliferation of the ductus arteriosus that leads to an anatomic closure a few days after delivery. We are looking at low birth weight babies. These babies, some of them are preterm on the basis of being premature. Some are term, preterm, but they're way below the 10th centile for age. So especially for the preterm babies, of course, the PDA does not get to close just like it will close in older babies. So it becomes patent. Now, we have the window of opportunity to close the PDA. As a matter of fact, we do that routinely in our center by pharmacological means. So far back, it was the use of indomethacin, but this had to stop because of the side effect. Then it advanced to using NSAIDs, ibuprofen. But again, how do you use ibuprofen? Maybe in a baby who is NIPE oral and you want to avoid NSAID-induced gastritis. So paracetamol, as plain as it is, can be used for closure of the PDA. So it's diagnosed, okay, first of all, you hear the machinery murmur at the upper left sternal border. When you say upper left sternal border, it becomes a challenge in these babies that have very tiny chest wall, maybe it's about as small as my palm, and the stethoscope bell is going to cover everywhere. So the upper part of the chest, anyway, you hear that continuous murmur all through the face of the cardiac cycle, bounding pulses, and then echocardiography can detect it clearly. So it is closed. These are challenges. Wow, I went too far into management of the challenges. So these are challenges. So we restrict to listing the challenges first before the management. So other challenges.
Okay, so for the hematological challenge, we have anemia and hyperbilirubinemia. We also have the gastrointestinal challenges, necrotizing enterocolitis. Of course, this is seen in preterm babies because once they are born, ideally, you're supposed to leave the gut to rest and at least allow for some bit of maturation. So if the child is actually being properly taken care of, this can be avoided. And of course, you can diagnose this using as simple as an ultrasound scan, which for us in our center, we actually have ones in our neonatal intensive care units. By the side of the baby can be diagnosed immediately.
Yeah, so portal venous gas, and then even X-ray can be detected. Sorry, a little talk on anemia. If we say anemia in low birth weight babies, premature babies, low birth weight babies, anemia because there's deficient production at that age. And then anemia or prematurity, maybe that will not fall under chronic. So acute anemia, anemia or prematurity, because there's this physiologic nadir, the drop of hematocrit in preterm babies at 6 weeks. Now, for these ones, it could be exaggerated. So when babies are treated and for any reason discharged before 6 weeks, preterm babies, low birth babies, follow-up appointment must be between 5 and 6 weeks of gestation to be able to pick early before it gets too bad and for interventions to occur on time. Okay, fine. So we have other systemic challenges.
Okay, so for the metabolic challenges, we have the glucose and calcium metabolism, which is a bit impaired in premature and low birth weight babies. So you have a challenge of this. Then we'll further discuss how we can take care of these challenges and address them. We also have a low GFR for those, their renal challenges and inability to handle solid load.
Yes,
so their fluid must be regulated at every point in time.
Yes.
For every age, there's a fluid, and for their weight too. Then also we have.
So that's the reason why for preterm babies, we are very particular about the dose of the fluid and the constituents of the fluid we are administering. So you see, they have low glomerular filtration rate. They cannot handle solids within the first 48 to 72 hours. So we want to give them plain dextrose containing fluid at 70 to 80 mils per kg in 24 hours and can increase by 10 mils per kg per day as it goes. So you do not want to overload them because of renal function. You do not want to overload them because you don't want to keep the ductus arteriosus that may be closing patent because of overloading. They have problem with temperature regulation also. Of course, adipose tissue is low here, and thermoregulation is a significant issue because they should have been in the warmth of their mother's wombs, but delivered quite early. That is talking about preterms. Now, but what of the low birth weight due to intrauterine growth restriction? Also, adipose tissue is less, temperature regulation is a major challenge.
So this can be taken care of with the incubator, of course.
Yes, incubator care. We'll handle management subsequently.
So they also have immunological challenges. The humoral and cellular immune responses are also deficient. Then they also have the retinopathy of prematurity, which is majorly a complication of high oxygen concentration. That's why we were discussing that initially.
Yeah. Yeah, so retrolentia fibroplasia, which is an old name for retinopathy of prematurity. Whenever we remember retinopathy of prematurity, we put side by side with the chronic lung problem in them, bronchopulmonary dysplasia, because these are two complications of oxygen therapy of high dose oxygen in these babies. So bear that in mind. Now, we've talked about the epidemiology of low birth weight. We've talked about the risk factors of low birth weight. We've talked about the challenges of low birth weight. Now, I want to approach the management of low birth weight babies in resource-constrained settings, like Nigeria, where we find ourselves. Nigeria that has the largest burden of low birth weight deaths, of neonatal deaths of over 700 deaths per day, greater than 29 deaths of neonates per hour. So we want to look at this management under 4 subheadings. How do we care for them before their mothers conceive? And when a mother has conceived, how do we care for them before they are delivered? And at the point of delivery, what can be done and what could be done just after delivery? So we'll take them one by one. So preconceptional care.
So this is the care that we'll give to the woman even before she gets pregnant. By the way, happy International Women's Day. That was yesterday. So the women are very important to us. And that's why part of this discussion has to be focused on them, because they are the carriers of these babies that we're discussing. So of course, we are already handling one of the preconceptional care, which is the public health enlightenment, like we are doing right now, trying to create awareness and tell us how we can prevent all this. So public health enlightenment, then making sure that women everywhere know that they should receive antenatal care services. So they should be booked, they should enroll with a health insurance scheme. The Limi hospital actually has its own health insurance scheme, and we also provide very good antenatal care and services. So ensure to book with us if you're pregnant or you plan to get pregnant anytime soon. So we should also know that avoidance of substance abuse and also specific medication use. Some medications should not be used during pregnancy or if you're hoping to get pregnant. I think the anticonvulsants are among these medications. Then also adequate nutrition. That's another important aspect. So every woman should be well fed, every girl child should be well fed, but she would still be a mother, hopefully, of a child.
Yeah, so you know, our first slide in the presentation says a good start in life begins in the womb. So a mother who is malnourished will definitely have a malnourished baby, a baby that has a restricted growth in utero. And that is what we want to make sure we do everything to prevent. So adequate nutrition of these mothers before they conceive matters a lot. Fine.
So we'll discuss the antenatal care.
No, still preconception.
Okay, we're still under preconceptional care. Okay, like we discussed the risk factors, so you should be aware of high-risk maternal ages. This does not mean that people that fall within these age groups cannot get pregnant. It just means that once you know you fall under this age group, you should be very proactive, make sure that you book for your antenatal visits, go for them, and then whichever the urban guy is handling, you should also be on alert to watch for any features or any sign pointing to intrauterine growth restriction, which can actually be diagnosed using ultrasound scan while the woman is still pregnant. Also, adequate interpregnancy interval. According to the World Health Organization, the adequate interpregnancy interval is between 18 months to 16 months. So a long interval is also bad and a short interval is also bad. So you need time for the body to actually get back to its pre-pregnancy state. So you need to replace the blood. If not, you could get into chronic anemia, which is also one of the risk factors for low birth weight. Then folate supplementation and adequate control of background chronic medical conditions like diabetes mellitus and other chronic diseases like hypertension as well.
Yeah, so fine. So before we proceed, we will stop to pause to answer a lot of questions on our chat box. Can you please, can we have reference backing up the Taiwan study? No problem. For everybody that registered for this presentation, the full presentation will be sent to the person, so you'll get it free of charge. Now, the next question, a baby that was delivered via CS with general anesthesia given to the mother, how does it affect Ballard scoring, especially if the baby is not full-term? It's simple, it's straightforward. The scoring, we understand the limitations of neuromuscular maturity. However, what we see is what we see, and we know that it augments the obstetric report. So many mothers, let me not say many, some mothers may have forgotten their last menstrual period. Some may not have done an obstetric scan within the first trimester of pregnancy. But now the Ballard scoring, what we see, we report just like that. Now, the issue of respiratory distress syndrome in infants of diabetic mother have been answered. What about developmental dysplasia of the hip? How common is it in low birth weight in our environment? Well, you know, when rare diseases are not looked for, it is called rare. Just like it is said that when somebody is not a dermatologist, everything is rash. But the dermatologist knows the difference. So you look out for it, you find it. What's the cutoff for anemia in preterm babies, and what's the management of anemia? Okay, we'll look at management as we progress in the discussion. Which state in Nigeria has the highest number of neonatal deaths? How can Limi Children's Hospital help? Wow. So Nigeria, we have the largest body. A search of literature could easily help to find out, but you know, there's paucity of data in our environment largely. And the problem is when something is not reported, you cannot find. So we looked at the United Nations chart and found that sub-Saharan Africa, up to 60% were not weighed. So when you do not weigh, you will not know. No. But these things are prone. So we would hopefully have collaborations for large public health researches to be able to find this. The plans are possible to work out. How are preterm babies at risk of non-communicable diseases later in life? So this question may want to take us to the concept of fetal origin of adult disease. So it's an entire concept of its own, fetal origin. So you could actually check that up on Google, fetal origin. So there is, if you take renal, for an example, these babies are born preterm or low birth weight. The nephron mass is below what is expected. Now, even if the baby was born preterm with adequate nephron mass relative to gestational age, we know that glomerular filtration rate is suboptimal. Now, but because of intrauterine growth restriction with development of this, I'm just looking at renal, for example, now, not well formed, they have depressed renal function and ultimately culminate later in life having renal disease. So most of these problems are organ specific because of the onset. So does it occur? Yes, it occurs. And it is under the broad concept of fetal origin of adult disease. That could be another topic that would be very, very interesting to talk about. Fine. Let's see other questions in the chat. Okay, fine. So we'll continue. We've talked about preconceptional care. Now the woman has become pregnant. The woman who celebrates Happy Mother's Day has become pregnant. So let us see antenatal care. So antenatal interventions for the mother. Now, from WHO documents, following a lot of systematic review and meta-analysis. So based on levels of evidence, strength of recommendation, and levels of evidence, it is known that antenatal corticosteroids improve neonatal outcomes. Now, babies are at risk of preterm, pregnancies at risk of preterm deliveries between 24 and 34 weeks should have their mothers receive antenatal corticosteroids, either intramuscular dexamethasone or intramuscular betamethasone. When preterm delivery is imminent within 1 week to 1 day, it's important that this is given. Now, it's important that we note a contraindication for antenatal steroid, which is infection. So preterm pre-labor rupture of membrane, while it is an indication, those that have now suffered chorioamnionitis should not receive. Babies who are born, mothers who had pre-gestational diabetes and gestational diabetes risking imminent deliveries should both receive corticosteroids and also have glycemic levels adequately controlled. We would be glad to have the comments posted under the chat box so that we can respond to it. We see some virtual hands raised up. Okay, fine. Still on antenatal care, we talk about magnesium sulfate. What about it?
So magnesium sulfate can actually also be given to prevent the risk of imminent preterm delivery, and it also helps in the prevention of cerebral palsy. Then also the erythromycin can also be administered. It's recommended for women with a preterm pre-labor rupture of membrane. Is the first drug of choice for chorioamnionitis.
Yeah. So the earlier it is given before chorioamnionitis sets in, the better. So other antenatal interventions. So these mothers should have obstetric scans, both for estimation of dates of delivery, which should be done at first trimester, and then for monitoring of growth of the babies. So fetal growth monitoring, daily iron and folic acid supplementation is very, very important. Then for mothers who have previous preterm deliveries, or those who have short cervix, should have cervical sacrilege put in place. This will help a lot to prevent early delivery. Now, progesterone therapy for mothers at risk of preterm deliveries. These are mothers who would have been followed up so closely, and then any risk can easily be picked on time. Yeah, so we looked at preconceptional care, antenatal care. So what next? Perinatal care.
So all low birth neonates, no birth weight neonates are at high risk, and so the pediatrician or healthcare personnel must always have adequate neonatal resuscitation skills. You can see the picture of one of our trainings here in the hospital. So the pediatrician or whoever is going to handle the child should at least have had adequate training on neonatal resuscitation, and then intrauterine transfer of high-risk deliveries to facility. Like the case scenario that we discussed, so the baby was transferred from a specialist hospital. So there's the opportunity for you to actually transfer the mother and the child before the child is delivered to a facility that has adequate resources and manpower to take care of a low birth weight neonate. Then prompt referral with appropriate use of appropriate transport tools, like use of a transport incubator.
Yeah. So again, so let's look at the question we put on the chat. How best would that baby have been transported? We have the mobile transport incubators. So the baby should have been transported inside the transport incubator. But if that is not absolutely possible, we have one in our center. So the center could simply have collaborated. We send the mobile incubator to transport the baby down. Or with the healthcare worker, the supervised kangaroo mother care, KMC, with a skin-to-skin contact of the baby and the mother in transit to us. But we'll look at that question in more details at the end. So neonatal resuscitation skill is of utmost importance for everybody who is going to attend to deliveries. So whereas we do webinar sessions every monthly from Limi Children's Hospital, we also ask our esteemed audience to watch out for our advert on Pediatric Symposium, which usually holds towards the last quarter of every year, where practical sessions would be held also. So we also see more on care of these babies. So early neonatal care. Yeah,
So for early neonatal care, that's once the baby is delivered, The kangaroo mother care should be done for stable newborns weighing 2,000 grams or less at birth. The key word here is stable, and it should be initiated in the healthcare facility as soon as the baby is certified stable clinically by the doctor, the pediatrician. The kangaroo mother care should be commenced. It's skin-to-skin contact. So as the picture shows, the baby must be in direct contact with the mother's skin, and it should be a prolonged contact. It's not a short thing. So the comfort of the mother must be taken into cognizance so that she can have a good place to rest and carry the baby skin to skin for a prolonged time. We could also encourage exclusive breastfeeding. Of course, that's what should be done ideally. Or if the baby is not yet stable enough to suck directly, you can still give the expressed breast milk.
Okay. Yeah. So a little more on kangaroo mother care. We see this mother with the skin exposed and the baby's skin also exposed. The baby lying in between the mother's breasts, but the nose is not in contact with the skin, so the baby does not suffocate. The baby gets to bond with the mother in this posture. Adequate colonization of maternal flora with the baby to help immunity. The mother's heartbeat helps to stimulate the baby's heartbeat. The baby is in a reclined position, so gravity helps digestion of food. In case the baby has apnea, those who may develop apnea, the continuous breathing movement and the heartbeat of the mother is a stimulus for the baby. Now, a little thing about kangaroo mother care. Fathers would also help in so if it's not called kangaroo father care anyway, the idea in kangaroo mother care is that there is skin-to-skin contact. So how will you handle this if the mother has twins, the mother has triplets? So the fathers will step in to help in this scenario, or a close relative. So the most important thing is that the mother is positioned reclined to about 45 degrees in a comfortable position with exposure to the baby's skin to skin. There's a feeding aspect of the baby. There is psychological support for the mother, and this helps early discharge. Now, for babies that are unstable and way below 2,000 grams, they should be nursed inside incubator. Now, the fact is that incubators have levels. Now, there is a general incubator. We have GE products that are actually called smart incubators. So these are incubators that automatically weigh the baby, controls air current, controls generally. So smart incubators are actually ideal where facilities exist. However, the regular incubators are also important. Now, transport incubators become essential for transfer of babies between centers, especially collaborating for better care. But bear in mind that in utero transfer would have been better, which my colleague had just talked about. Okay, so we talk about continuous positive airway pressure in case of respiratory distress. The key word is start early. You start early. We'll see a little more about parameters of the continuous positive airway pressure. Now, minimally invasive surfactant therapy as surfactant administration for selective cases, because remember we are talking about low birth weight babies. Now, low birth weight could be preterm. Those who are preterm that have respiratory distress syndrome should be giving surfactant as soon as it's detected. Now, but some babies are actually post-term but low birth weight. Those ones do not fall under. So it's not a blanket rule that all low birth weight babies are given surfactant. That should be very, very clear. Okay, fine. So during ventilation of babies, you are talking of using the actual CPAP machine. Yeah, we know CPAP can be improvised, but we would talk about levels of care that is available. So in resource-constrained settings, yeah, it could be improvised, but bearing in mind that that is just a bridge to the actual CPAP machine. So during ventilation of preterm babies below 32 weeks, you start with oxygen therapy at 30% of air, 30% oxygen or air, not 100%. Now, we don't want to use 100%. We've talked about retinopathy or prematurity and bronchopulmonary dysplasia.
dysplasia.
So use of progressively higher concentration should only be considered for newborn. So this is the only indication why you may increase concentration of oxygen. Now, if the patient is bradycardic for more than half a minute, bradycardia for more than half a minute, you would increase until you get adequate response. So let's look at target oxygen levels. The slide here is important because if I meet a preterm baby delivered, let's say 30 weeks, fine. At 10 minutes, I am not looking for saturation of 100%. So that's one thing. So we bear in mind that if you meet this baby, of course, the pediatrician should attend theater or labor ward delivery of these high-risk neonates. So as soon as they come out, by the time you are taking the 5th minute APGAR score, you are not expecting saturation that may be more than 90%. This should not raise alarm. This should not raise alarm. As they get older in minutes and proper exposure to oxygen, it could increase. So you can adjust the concentration of oxygen on the CPAP. This is one of our CPAP machines. It's actually a smart CPAP machine with screen functions that it can perform both CPAP functions and even ventilator, mechanical ventilatory. Okay, yeah. So we are back on air again. Sincere apologies from presentation coming from a resource constrained country by a center that has the resources bold enough to make an impact. Thank you. So we want to broadly look at, because we would like to touch as much as possible the interventions that could be done. So we've looked at oxygen therapy, we've looked at control of warmth. What about other issues like glycemic control? Remember we said metabolic problems, they have dysregulation of glucose metabolism. So they could have hypoglycemia, hyperglycemia. And for these babies, you do not want random blood sugar to drop below 3 millimoles per liter. So the concept of glucose infusion rates become very important and should be very clear, with no ambiguity in the mind of anybody taking care of low birth weight babies. So we said earlier that you give fluid volumes of 70 to 80 mils per kg for day 1 and increase by 10 mils per kg per day. However, what type of fluid will you give to ensure the child does not get hypoglycemic? We know that hypoglycemia is a risk factor for a lot of other problems. In fact, intellectual, low performance, cerebral palsy, all those problems. So with a glucose infusion rate for a baby who we find to be hypoglycemic, what do we do? The formula should be very clear as 200 to 400 milligram per kg of glucose should be given within 1 minute. Now, how then do you calculate this? I know it's quite easy to say where you have 10% dextrose water, you use 2 to 4 mils per kg. But it's important to know that it's 200 to 400 milligram per kg of dextrose, because if you have 5% dextrose, you know how to make the calculation. If you have a higher concentration of dextrose, the most important thing is that the loading dose is 200 to 400 milligram per kg, giving over 1 minute. So this is not what you want to give over. You want to get it out. This is all like shock. You find a child in shock, you want to give bolus to get the child out of shock immediately. So we get a child in hypoglycemia, you give the loading dose within 1 minute. Now, when that is done, you know that dextrose has been infused into the baby. We've jacked up the random blood sugar within 1 minute. Mind you, insulin will rise up because we've challenged the pancreas to form. Insulin will rise up to mop up that effect. So how do we now control? So we need a glucose, maintain it at a glucose infusion rate of 6 to 8 milligram per kg per minute. Therein lies the challenge with calculation for many people. And it shouldn't be a problem at all. Let me repeat myself. You want a glucose infusion rate of 6 to 8 milligram per kg per minute. So I am looking on the table with the baby by my side. I have 5% dextrose, I have 10% dextrose, I have 50% dextrose. How will I arrive at, let's say, 7 milligram per kg per minute? Quite simple. There is a formula of glucose infusion rate is equal to the concentration of dextrose you want to give multiplied by the mils per kg of fluid you want to give per day over a constant of 144. Now, this should be very clear. We do not want to overhydrate this baby. So if our calculated fluid for the day per volume is, let's say, day 1, and the baby we are supposed to give 70 to 80, let's say we want to use 80. So it will be 80 because 80 mils per kg times an unknown concentration of dextrose you want to give over 144, fine. And you put the constant, the infusion rate at 7. You make that glucose concentration the subject of formula, you get the volt concentration. So you may realize that the calculated concentration would be 12.5. Calculated concentration would be 15%. Therein lies another problem. Because the fluids available are 5%, 10%, 50%. So a simplistic approach, you say, what if you mix 5% dextrose and 10%? That's rubbish. You won't get what you are looking for. So you want to make up 10% dextrose to 15. Let's say you want to make it up to 14.7. We've done that before. So you have 10% dextrose. But the calculated concentration to keep this child euglycemic is 14.7. So how do you make up the fluid? So expected is 14.7. What you have is 10%. So what is the difference? The difference is 4.7. The difference between 14.7 and 14.7% and 10% is 4.7. Multiplied by a constant of 10, that becomes 47. Very simple. So you discard 47 mils from a bag of 500 mils of 10% dextrose and replace with 47 mils of 50% dextrose. Simple. You have reconstituted that fluid to 14.7%. So with that, you maintain euglycemia. It's important because glycemic, we do not want mental retardation in our babies. So glycemic control is of utmost importance. So also total or partial parenteral nutrition. So for us,
okay, sorry, I think the guests would see if we can drop some of these formulas in the slide before we send it to them.
Okay, yeah. It's okay.
Discussing mathematics sometimes.
It's okay, fine. So total or partial parenteral nutrition, the difference is in lipids. So if you use lipids in addition to the other component like protein, which are calculated from amino acids or the dextrose calculation. So if you can accurately calculate glucose infusion rate, you will be able to calculate the percentage of dextrose as a component of your parenteral nutrition fluid. So that's why it is of utmost importance. Also amino acid and then lipids, electrolytes and lipids. Other issues in neonatal care include infection control practices. IPC, infection control practices necessary. So quite simple, hand washing technique. It should be very clear, the steps of hand washing to make sure that we wash clearly so we don't transfer microbes to the babies. Face mask. I think COVID has helped to take care of that a lot. So by default, we are all on face masks, except those of us presenting that we have the special privilege so you can see our faces. So infection control.
Having standard of operations, like
So, yeah.
in our own
So we have like in our neonatal intensive care unit, we have NICU asepsis SOP. So this is very, very clear, and the nurse in charge would drag you back, would emphasize, no, you can't do this. So infection control practice handled critically by the nurse there. So neonatal antibiotic stewardship becomes very, very important. Neonatal antibiotic stewardship. Currently, there is a new trend of new program on pediatric antimicrobial stewardship, which we are happy to say that Limi Hospital is the only private hospital selected for the training. All our nurses, doctors, pharmacists, lab have been trained. Yeah, and the program is going to run for a whole year. Now we are tracking it down to neonatal care. So in antibiotic stewardship, we want to avoid antimicrobial resistance. So we get to know what is the appropriate antibiotic based on standard guidelines. What is the dose, optimal dose, at what duration, what route of administration becomes very, very necessary for antibiotic stewardship. There is this question here. Please, can you explain glucose calculation for maintaining blood glucose in a unit? Maybe let me repeat myself quickly, but I'm sure we may have to include that in the slide before we send. We said, okay, let's say we meet a child that is hypoglycemic, random blood sugar in unit, random blood sugar below 3 millimoles per liter. We want to give a loading dose of dextrose, and the loading dose is 200 to 400 milligram per kg of dextrose, given within 1 minute. Given within 1 minute. But because 10% dextrose is readily available, you could just loosely say 2 to 4 mils per kg of 10% dextrose. But 10% dextrose may not always be available. So it's important to be able to calculate it in millimoles anyway. Now, that done does not solve the entire problem, because once the loading dose is given, within 1 minute, blood glucose, random blood sugar improves. But it's not like we've called, so what we say, who let the dogs out? So insulin will just surge to mop it up. So if we do not maintain, we have a rebound hypoglycemia, and that's what we do not want. For every episode, every encounter of hypoglycemia, a mental retardation, neurologic dysfunction is what we do not want to experience. So how do we maintain dextrose infusion? So that's the concept of glucose infusion rates. We say the formula, the glucose infusion rate should be 6 to 8 milligram per kg per minute of dextrose. We are not saying 6 to 8 milligram per kg per minute of 10% dextrose. No, it's glucose. So whatever formulation of glucose you can give, provided you do not overload this child, you attain a glucose. So when I calculate a glucose infusion rate of 7 milligram per kg per minute, I can sleep knowing that it was an adequate calculation, and provided the intravenous access is patent, that child will not have hypoglycemia, at least in most cases, except there is an insulin secreting tumor or something that increases catabolism. In that instance, you know, I said 7, so you can operate at the level of 8 milligram per kg per minute. But how do you achieve this? We said, maybe let me explain a bit. So glucose infusion rate, GIR, is equal to the concentration of dextrose you want to give.
That's the percentage dextrose.
Yeah, the percentage dextrose, which could be 10%, which could be 15%. Mind you, by the time you are going above 12.5%, you do not want to use peripheral lines. Central lines like umbilical venous catheterization becomes very, very important. Okay, fine. So glucose infusion is equal to the concentration of dextrose multiplied by the volume per kg per day, not the absolute volume. So because a child that weighs 2 kg and you want to give 80 mils per kg per day, absolute volume is 160 mils, not absolute volume, is a mils per kg per day. So you say 80 over a constant of 144. So you can try this out, and I dare say that 10% dextrose really is not adequate to maintain euglycemia in these preterm babies. Why? Do the maths. So you say you do not know what the glucose infusion rate is, but you just say 10 as a concentration of dextrose multiplied by, let's say, 70 mils per kg over 144. Can somebody in the audience, in our physical audience, do the calculation? Let's see. So we say 10 times 70 over 144. 4.86. So that's going to give a glucose infusion rate of 4.86, whereas way below the target. The target should be 6 minimum. So you see, so some people just blindly say place on 10% dextrose. No, I think probably that should be a new knowledge, something a lot of people should pick from this. Glucose calculation is of utmost importance in these low birth weight babies, that we are calculating not on the basis of what the pharmaceutical companies have packaged for us, but rather we make out the concentration of dextrose necessary for this baby. So now we have on our table 10% dextrose, 50% dextrose, and we want to ensure we have euglycemia. So we want to say we want to get 6 milligram per kg per minute as our glucose infusion rate. That is equal to a concentration of dextrose we want to determine multiplied by the volume per kg per day. Now we used 70 mils per kg the last time. So let's do the calculation from the audience again. So we say an unknown X, which is a dextrose concentration, multiplied by 70 over a constant of 144 equal to 7. If you find X, which is the subject of the formula, let's see, what do we get as a glucose infusion rate? Huh? Okay, fine. So good, very good. So if you use that, you get a very high glucose infusion rate, which will very likely give you hyperglycemia. Very good. So if glucose infusion rate is calculated above 8, the child risks getting hyperglycemia. So what do we do in this situation? The child still has allowance for what? For both the actual glucose infusion we want to calculate and the volume. The volume. So let's see, we want to use, this child is day 1 of life. We now want to use 80 mils per kg per day. We want to get a, what we did was, we calculated
for the percentage concentration.
That 12.1 was the percentage concentration.
Yeah.
So let's rewind. We wanted to get a 6 milligram per kg per minute of glucose infusion rate with an unknown concentration of dextrose at a fluid volume of 70 mils per kg per day. So unknown glucose concentration multiplied by 70 over 144 equal to 6. If you find X is 12.5. So it is the concentration of dextrose should actually be 12.5%. So 12.5% dextrose is what will maintain euglycemia. Now, there is no pharmacy store that sells prepackaged 12.5% dextrose. So you need to constitute it, which we have explained just recently. Fine. So we've talked about other neonatal care. So let's just quickly go back. So there's a question here. What's the choice of antibiotics in preterms in case of presumed sepsis and the dose? Well, now, World Health Organization has the AWARE classification of antibiotics. So we should know from the Antimicrobial Stewardship Program, they are aware.
Assess drugs.
So they assess drugs that you can easily assess. In this class, this class of drugs are readily available. They are usually broad spectrum antibiotics. That's the AWARE. So AWARE, then the watch class. Those are narrower spectrum antibiotics that should be used based on culture sensitivity recommendation. So we say AWARE again. The last class is the reserve. The reserve should be used sparingly. The essence of this WHO classification is to prevent antimicrobial resistance. Bearing this in mind, we would simply say a simple answer to this question, we follow, since we're in Nigeria, we follow the PAN guidelines, Pediatric Association of Nigeria guidelines for sepsis. It is actually better to be able to make a proper diagnosis of sepsis anyway. So if you are giving antibiotics, same presumed sepsis is a hanging thing. Sepsis is there, sepsis is not there. It's very important. Although you may want to say you want to give prophylactically, well, that's a little controversial because they have low deficiencies in humoral and cellular immunity. Means we said infection control practices will help a lot. But if you have to give commonly, the PAN guidelines talk about the PAN guideline has a lot doing with their weight classification anyway. So amoxicillin, so unacin is a combination of amoxicillin and sulbactam. So that's class, penicillin class with an aminoglycoside, first line. If that fails, then we can now go to the cephalosporins. So cephalosporins, not ceftriaxone, very importantly, not ceftriaxone, because we do not want to cause biliary sludging, to cause hyperbilirubinemia in these babies. So ceftriaxone is out of it. So ceftazidime, cefuroxime, cefuroxime, ceftazidime, they can be used, but again with the aminoglycoside backbone. By the time you are reaching this stage, you are actually, you should have been getting your culture results, because at admission, at the point of getting them, blood culture should have been taken. So actually, by then with backtech technology, we should have been able to get results on time and we use appropriately. Let's see if there are other questions. Does the weight of a baby affect the GIR, since the weight may affect metabolism? Yeah, we said that when the baby is low birth weight, especially because of intrauterine growth restriction, nephron mass is below what is expected. Yes, it does. Okay, so let's round up with our case scenario and see how much of the answers we've been able to get as we round up the presentation.
Okay, so going back to our case scenario, which we said initially, the 6-hour-old preterm female weighing 1,300 grams, a 30-weeker, delivered at 30 weeks gestational age by a vaginal delivery to a 37-year-old multigravida who was on treatment for urinary tract infection, referred from a specialist hospital to another on account of no bed space. The baby was transported by the mother without any healthcare worker, and the RBS on arrival was 2.2 millimole per liter, the respiratory rate 78 breaths per minute, and the saturation was 90%. So these are the questions. I think we've answered most of the questions from our presentation. We've classified the birth weights as very low birth weights, which is those below 1,500 grams.
Yeah.
And we've seen the risk factors. We discussed the risk factors, the age, extreme of ages. This mother, we can see, is 37 years. And we said that above 35 years and less than 16 years. So she falls within that category. So that is one of the risk factors, the age. And then she was on treatment for an infection, urinary tract infection. We discussed that infections were one of the risk factors. We called a couple of them. We said urinary tract infection. We talked about touch infection. And we also discussed about the immediate health challenges. For this child now, we can see that the child came with hypoglycemia, which is one of the challenges you see in the first 2 to 3 days of life. Also came with tachypneic and desaturation too. So those were the immediate health challenges that this child had. For those that got it, we're on track. Then how do we manage them? We've already discussed this. For this child, with this birth weight, the child is an unstable newborn. So this child will require incubator care, first and foremost, because the child is less than 2,000 grams. The child will also require the monitoring, oxygen support, of course. The respiratory rate is down, the saturation is also low. This child will require monitoring of the glucose. We need nutritional support. Using our GIR, we can calculate the appropriate percentage dextrose that this child will require. Am I missing any other thing?
Okay, no, basically that. Then we also always never forget infection.
Infection control.
Infection
Very
control.
important. Because this
So
child
for
is
this child,
sepsis.
the baby has risk factors for sepsis. The mother had urinary tract infection, and the baby is preterm, and the baby was transported without infection control practices. So you have to do so. How should this baby be transferred to us? In neonatal transports, we expect one that the referring center would do a communication with the receiving center. At least let the units be set to receive the baby. Then this baby should have been transferred inside a neonatal, a transport incubator. So simply the referring hospital could have placed a call. Our ambulance would have rushed down to receive the baby inside the transport incubator. That would have been necessary. Accompanied by healthcare workers, because if along the line the child was found to be hypoglycemic, correction could have continued, has commenced in transit. So we reduce the time for all those challenges. So we've been able to address this question. So we will round up by looking at the World Health Organization levels of newborn care interventions that are adopted for low birth weight babies. That will be the last slide as we end. But let us check, okay, fine, for comments. So levels of care for the baby. So newborn care, immediate newborn care, early cord clamping, taking care of, those are the early neonatal resuscitation, taking care of the babies. Very, very essential.
To refer if the child requires referral.
Yes. So that comes under special care. So in under special care, talking of thermal care, including kangaroo mother care for all stable babies, which we've talked about, assisted feeding and IV fluids, which we've discussed in details a lot about the fluid calculation, safe administration of oxygen. There was a question about, so what's the cutoff for respiratory rate for preterms? So neonates, generally 60. We do not want 60, above 60 is tachypnea. Oxygen, somebody also asked about dose of oxygen. Fraction of inspired oxygen, we want to start about 30%. Then we adjust based on response. Detection and management of neonatal sepsis and adequate antibiotic stewardship. Management of neonatal jaundice with phototherapy, neonatal encephalopathy, then detection and referral of congenital anomalies. We saw in one of our earlier slides that our pediatric cardiologist was performing neonatal echocardiography inside an incubator. So congenital abnormalities should be detected at this stage. Now, as a transition between level 2 and level 3, CPAP management of preterm respiratory distress is absolutely important. Follow-up of babies who are high-risk neonates. So follow-up, we say if for any reason a preterm was discharged before 6 weeks, that baby must be seen at 6 weeks because of anemia of prematurity. Yes. So level 3, which is actually intensive care, is mechanical and assisted ventilation. So our ventilator can take babies below 10 kg. So it's a smart ventilator by the GE company. So we can take from 0. whatever till up to 10. So mechanical ventilation. As advanced feeding options like parenteral nutrition. Yeah, so we have our protocol for partial parenteral nutrition for now because we don't do lipids yet. And investigation and care for congenital conditions, yes, like the screening for babies with congenital disease, screening for retinopathy or prematurities. So one very strong learning point from here, we hate, or neonates, we pediatricians hate 100% oxygen given to preterm babies. We do not want to be heroic in managing the early conditions and let them grow with blindness. That is avoidable based on knowledge.
Okay, so our own neonatal units here is under the level 3.
Yeah, so
we provide all these services.
Yeah, thank you. So that's level 3 function. So now let's conclude because it's time to take dinner. So let's conclude. So we want to reduce prevalence of low birth weights. We want to contribute to reduction before 2025 based on World Health Assembly and based on the Sustainable Development Goals by 2030. So obstetric care optimization is crucial. So we see that obstetricians play a lot of role here. Doctors in general, health workers, we say as preconceptional care as simple as enlightenment goes a long way to help. So the mother who is 39 years old, shouldn't she have babies? We don't want to stop her from multiplying and replenishing the earth. But if that must occur, she must understand the fact that there is risk of low birth weight ahead of time and make adequate preparation. We want to reduce as much as possible. Now, collaborations between centers and neonatal specialist care centers, between birth centers and where they can get adequate care is crucial for the survival of these babies. It's of utmost importance. If these are done, we'll be able to attain Sustainable Development Goal 3 that talks about good health care for all, with a focus now on neonates, that by 2030, we'll be able to end preventable deaths of newborns and reduce neonatal mortality to less than 12 per 1,000 live births. This is possible when we work together. Thank you from a very healthy baby looking at you in front of you. And then thank you from me and my colleague from Limi Children's Hospital. Thank you. So we would want to see if we can get questions from our physical audience. We've been able to answer a lot of questions from our virtual audience. We'll still see if we can take more. We've literally addressed, yeah, fine. So, but we are still open to questions in all. Yeah. Okay, so essentially that we are grateful to our attendees, our participants who have, okay, I think this is a question. Okay, thanks to our virtual audience congratulating us. And with this, we come to the end of our presentation for today. Please watch out for webinar presentation for next month. We shall broadcast another very interesting topic. Our pediatric neurology team will be presenting next month. Like I said, this is our contribution to great healthcare. We are celebrating our 40th anniversary, 40 and waxing stronger. Thank you all. So, right. Yeah, so there is a link sent to the question and answer box for the chat. The link is there. Yeah, so
Also
the WhatsApp, yeah, so the WhatsApp, so it will click the link and so you can join the group. Yeah.
So you get information on the CMEs and next webinars and always be updated on anything new.
Yeah. Okay. Yeah. Thank you.